right. And here we are back again with Dr. Corey.
Hey, this is Jacqueline from Lichen Sclerosus Support Network, where our mission is to empower people with lichen sclerosus by providing evidence-based education and support so that we can live in a world where those affected by lichen sclerosus are informed, educated, and get diagnosed early. If you find the information in our videos helpful, please consider donating your time or money so that we can continue our LS education and support efforts. So in today's video, we are going to be talking all about vulvar biopsies for lichen sclerosus. We're going to be chatting about things like false negatives, when is a good time to biopsy versus a bad time to biopsy, what certain biopsy results might mean, how many biopsies you should be getting, different types of biopsies that could potentially be used for vulvar lichen sclerosus diagnosis, and much more. And we have brought Dr. Corey Babb back with us again to dive deep into the topic of vulvar biopsies for lichen sclerosus, as this is something that we get tons of questions about. So we thought, who better than Dr. Babb to come and answer some of those questions. For folks who do not know Dr. Corey Babb, Dr. Corey Babb is a board-certified OB-GYN who specializes in genitopelvic and vulvovaginal disorders, such as lichen sclerosus, vaginismus, and pudendal neuralgia. He is currently on the board of ISHWISH, which is the International Society for the Study of Women's Sexual Health. He's a reviewer for multiple sexual health medicine journals. He's a respected lecturer and educator, and he's been featured in multiple national and international publications. He is the medical director of Haven Center, which is situated in Oklahoma, and his practice takes people from all over the globe. Now, with that, let's jump into things.
And with Dr. Corey Babb, thank you again so much for returning for the 12th video. I don't even know, I can't keep track anymore, but thank you for being here.
Oh, it's my pleasure. My pleasure as always. So.
Thank you. Yeah, so today we are going to talk all about biopsies for lichen sclerosus. And this may seem like this can be a 5-minute video, but there's actually a lot to discuss. We get so many questions about biopsies, and we're going to try and tackle all of those today with Dr. Babb. So let's start out real simple. What is the difference between, say, a clinical diagnosis and a biopsy diagnosis for lichen sclerosus? Because as far as I'm concerned, those are the only two ways to diagnose at this time.
Right. So clinical diagnosis, you're going to look at basically the patient's clinical presentation. So, what is their, in the case of vulvar LS, what does their vulva look like? Does it have, areas of those kind of white patches? Do you see scratch marks in it? Things like that. Does the patient's clinical history go in that, point towards something along those lines? So, this itching that wakes them up in the middle of the night, they get burning, it flares, things like that. Now, obviously, there's a lot of things that can occur on the vulva that have those same type of symptoms, and that's where the biopsy really comes in. And so when you get a biopsy, you actually have a tissue sample that then goes to a pathology lab, and they take this thing called like a microtome, basically, or cytotome, and it slices this little teeny tissue sample so thin that you can actually see a whole layer of it under the microscope. And so the pathologist will then look at it and say, I see this is, normal skin, or, oh, we've got a bunch of lymphocytes here. There's a loss of these things called reedy ridges in the case of LS. And so then they say this tissue is consistent with lichen sclerosus or vulvar psoriasis or whatever it may be. Right. And there you have your official diagnosis.
Got it. So do you ever diagnose clinically?
I mean, I tell patients I can have a very, very, very strong clinical suspicion, but that, and I put that on my notes, like highly suspicious for lichen sclerosus or things, but I am hesitant to give it a true diagnosis unless I actually have that tissue sample.
That's fair. And I was thinking, even when you were talking about the clinical picture, so like the scratch marks, for instance, I was thinking, that could also be lichen simplex chronicus.
Right.
In which case, you're not talking about long-term treatment, you'd be talking about short-term treatment. really focusing on breaking that itch scratch cycle. So if you saw scratch marks and as a clinician thought, okay, diagnosed with LS, then you're going to put them on long-term topical corticosteroids, which may not be necessary.
Right.
So I think that's where, things get interesting, because I really feel sometimes for clinicians, because diagnosing vulvar conditions is really, really challenging because they present so similar, both with respect to symptoms and signs. I mean, if we think of symptoms, almost every condition I can think of has an itch component and has some
Sure.
kind of
Right.
pain or discomfort component, right? And if you think like, what are the big symptoms of LS? It's like, okay, well, itch, pain with sex. And I'm like, well, even a yeast infection can lead to pain with sex. So it's, with symptoms, it's really challenging. And then with signs, it's really challenging too, because again, there's many things, even, white patches. Well, that could be vitiligo potentially, or other conditions. So it's really challenging to just clinically look and know for sure this is, what's going on. So I want to now get into a little bit more of the nitty gritty of biopsies. And a lot of this is coming from feedback that I get from patient communities, from people who have had biopsies. So let's start with false negatives. Do you know like how common are false negatives, and maybe what are some of the reasons that you could get a false negative on a biopsy for VLS?
I don't have a specific percentage for that, and I will say I think it also being kind of a vulvar center, we send all of our vulvar biopsies to dermatopathologists. So that's the other thing too, so I personally have not had a false negative that I'm aware of.
Right.
Now you think about, okay, so it comes back and maybe you have a regular pathologist that doesn't see a lot of skin stuff, and they say, well, I think this is just, there's a little bit of spongiosis, or these kind of non-specific terms. There's inflammation, could be blah, 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 blah. And a lot of times I will say the pathologists are pretty good about saying, here's a different, what's called differential.
Right, okay.
This or this or this or this. But it's something that the experience of the pathologist is going to be the biggest determining fact probably in what if you're going to get a false negative, or conversely a false positive,
Right.
So
yeah, and so the reason I ask is that what I hear a lot is that patients come into the office and say, I have pain, I have itch. Doctor's not really too sure what's going on. They decide to do a biopsy. It's really painful and sometimes very traumatic for the person going through it. And then they get the results and it says non-specific inflammation.
Right.
And that's a really frustrating thing to get back, because you've went through this procedure that is painful, that is, for some people traumatic, to basically get no answers. And then clinicians do two things with this. They say, oh, well, everyone has inflammation, it's fine, you're good, basically you can leave now, or we're going to treat you for LS anyway. And then people are kind of, they feel a little bit funny about that, because, well, they're expecting a biopsy to give a diagnosis, not give this like non-specific inflammation response. And so now they're like, well, the biopsy said non-specific inflammation, but my clinician is saying I'm going to treat you for LS anyway, but I don't know what to do anymore. So what's your take on non-specific inflammation as like the only thing that basically the pathologist gives back? What does that maybe mean, and what might you do with that as a clinician?
So what I have done in the past, actually, when I've had those kind of non-specific inflammations, is actually call and talk to the pathologist and be like, hey, this is what I'm thinking. This is this is a patient's history, because they just get literally a tiny piece of skin.
Right.
And at least on our labs, you say kind of a diagnosis code. And, so if I have a patient that I think, well, this is LS, well, my usual code for it is the one that goes with vulvar pruritus. So it's just itching.
Got it.
I'm not going to put a code on there of lichen sclerosus unless I know that's exactly what it is. So they say, okay, non-specific findings. So you call them, you say, okay, this is what this looks like. I see these things. Can you look specifically for this? And that has been really helpful. And the pathologists, in my experience, really like that because that gives them feedback too about things. So that would be my kind of recommendation. If you have a patient that has a non-specific finding, like if they can talk to the clinician that did the biopsy, and we can talk about different types of biopsies too. That can also change things. But have them reach back out to the pathologist and be like, hey, I think this is what this looks like. Can you actually really look for that, if you will?
Yeah. How long do they typically keep that sample? So because I'm thinking there are cases where your office is kind of different in that you move a lot quicker than other clinics, and I'm wondering if a patient gets told over the phone a non-specific inflammation from a nurse, and they want to ask the doctor to call the pathologist and get more feedback. Sometimes that can take weeks. How would that still be? Would the pathologist still have the sample? I don't know how long they keep those for typically.
I mean, it's probably going to vary from lab to lab.
Yeah.
I know that about at least a month for tissue samples. They're in formalin. They're kind of like formaldehyde, so it's they keep them for a lot longer than say a blood sample, which goes bad after however long.
Right. So, okay. Yeah, a month seems pretty good. So yeah, for anyone that maybe got that back, try to reach out to the doctor and get them to chat with the pathologist and get a little bit more information and feedback so they can build a better picture of what's going on, because steroids are wonderful at what they do for vulvar lichen sclerosus, but it's not necessarily something you want to be on for life if you don't have vulvar lichen sclerosus. Right. So me as a patient, I would want to know this is what I have so I can feel safe and comfortable with my treatment plan, versus feeling like, well, maybe I'm just going to throw steroids on something that doesn't need steroids, either make it worse or lead to some side effects downstream, which both of those cases don't sound good. I was going on the Facebook communities to kind of look for biopsy results, seeing what people were typically getting, because you get a lot of people that will post their biopsy results and be like, what does this mean? They gave me this, but no diagnosis. And it's just medical terms. I don't know what to do with this. And fair, even I had to go Google some of those to see what they meant. And so you did mention spongiosis, inflammation is usually something that is kind of almost always going to be present on these reports, but some of them will say lichenoid infiltrate, and to your point, loss of reedy ridges. But then on the report, they don't say has lichen sclerosus or confirmed lichen sclerosus or anything like that. So in these cases, we know that lichenoid infiltrate, loss of reedy ridges, these are things that a pathologist would look for to make that diagnosis. If you're seeing all of these terms basically listed out, would that suffice to say it is an LS diagnosis and the pathologist just didn't write that down? Or again, what would you do with that? And how would you explain that to a patient?
Sure. So I there have been a couple times, I will say, that I have seen those. I mean, it's like if it looks like a dog and it barks like a dog, it's probably a dog.
Right.
Type thing. And I've told the patient, hey, even though it's, this is what it found, but this is what we see in LS, and your clinical signs and symptoms are consistent with it. To me, that is enough to make that diagnosis. Right. Now, if they just say non-specific inflammatory markers and that's it, I mean, okay, can't really do a whole lot. But I mean, if they throw the buzzwords in there and just for whatever reason don't want to make that actual diagnosis, which maybe they don't feel comfortable with, maybe whatever. But you can always, the provider who did the biopsy always has the option to request a second, basically a second opinion on the biopsy. I've done that a couple of times too, just being like, I
Okay.
really think this is this. The first pathologist said, no, I don't think that's what it is at all. I said, can you just have one of your partners check or something like that, just because this patient's picture is screaming this diagnosis.
Yeah.
So, yeah.
And did it come back? Do those cases typically come back confirming your suspicion
So,
when you
like
have that group 2 consult, or?
It's been kind of a mixed bag.
Yeah.
I mean, one of the ones came back Paget's disease, which is a whole separate thing. I would say probably about 50% we get like say, yes, this is what lichen is, and the other 50, no, I agree with whoever it is that this is what this finding is. So, and then you say, okay, well, I've got 2 people that look at slides more than I do saying, no, it's not that. So I would, I feel comfortable saying, okay, even though it looks like this, it's, not exactly what it is.
That's so interesting about getting a second opinion. Typically, when we talk about second opinions, we think more of the patient advocating for a second opinion. And here it's a clinician advocating for a second opinion from the pathologist. So that's really neat to hear. What about vulvar lichen planus and lichen sclerosus? Is it possible if a patient has both and you do a biopsy, is it possible that the pathologist would say, confirmed lichen planus and lichen sclerosus? How would that work to get like both diagnosed?
I've never seen that on one sample.
Okay.
If and there are sometimes, I think the most biopsies I've ever done on a patient was like 6, and it was under anesthesia, and there was extenuating circumstances with that. But like, if you, like I said, I've never seen it with one tissue sample. I have seen, sample A is this, sample B is this, C is the same as A, things along those lines, but not ever from the same one.
Got it. Yeah, that makes sense. And actually, that brings a good question. So most of the time you'll hear people getting 1 biopsy, but sometimes you'll hear 2 and 3, and people will kind of, email us saying, the doctor did 3 or 4 or they wanted 2. How come? Like, I hear that you just need 1. Why did they need so many? What would be an instance where a clinician might need or want to do more than 1 biopsy?
So remember that the other thing we're using the biopsy for outside of just, actual diagnosis is severity of disease process. So if you have someone and they have, let's say they have a pretty textbook LS picture. You don't see anything that's concerning for any type of, vulvar precancerous cells or vulvar cancer. Doing 1 biopsy to kind of confirm things is totally, in my mind at least, okay. You go for like the worst looking tissue, do it there. The people that are getting the multiple biopsies are typically the ones that are having, like, hey, this looks like, but oh, this spot over here, this looks really weird. Like, if you say, okay, that could be precancerous, or this looks funky, or whatever, and trying to say that there's different severities on the tissue. And so if, you have multiple areas that could look problematic, it behooves you to, take samples from those areas. Now, personally, if I have to do more than 3 spots, I do it under sedation. Yeah. I'm not going to do that in the office. But 1 or 2, or like, is there 3 even, we definitely can do them in the office.
Yeah, fair enough. So speaking of severity of disease, one thing that I'm seeing being a big challenge, because it's almost positive and negative in a sense, I find that lichen sclerosus is getting a lot more awareness. In terms of clinicians, broadly speaking, even GPs are becoming a little bit more familiar with the condition, which is great on the one hand. But on the other, there's not as much training. So people are aware of it, but not very sure how to go about diagnosing it and don't really understand the complexity of it. Or because more people are aware of it, they throw that diagnosis out very easily to anyone that now comes in with itch and pain. It's like, okay, I'll give you some fluconazole. We'll assume yeast doesn't clear. Okay, it's lichen sclerosus. And so that's a problem on so many levels too, because just because VLS is more common than, previously construed doesn't mean that every case that walks into your office with itch pain is a lichen sclerosus patient. But another challenge is capturing lichen sclerosus when it is in that earlier stage. So it's pretty, not easy, but it's easier when there's clear signs on the vulva, right? There's some white lesions, there's some thickening, there's, some of that crinkly, not cigarette paper, wax paper, something like that. Texture, there's like clear signs, right? So like by the time I finally got my diagnosis, there was so much scarring. Like I had lost almost all the anatomy, clitoris completely fused over, resorption, white like my fate background. Like it was screaming, textbook. Now it would have been nice if I didn't have to progress to that stage to get, that diagnosis. It would have been nicer if I was caught earlier. However, then we become in this tricky part, because if it's so early that there's no signs yet manifesting on the vulva, what do we do with that? Because my understanding is that to do a biopsy, you do need some kind of clinical sign present, right? You wouldn't just biopsy a vulva that looks physically healthy, that has no lesions, no scarring, no nothing. So what do you do? Like a lot of doctors will say, or they'll get the non-specific inflammation and be like, well, this is clearly just mild LS. It hasn't had the chance to progress yet. So this is a mild case, and they'll deem kind of cases where there's no clinical signs yet as it's mild. Be happy we caught it early. So someone comes in, itch pain, doesn't respond to fluconazole. Okay, you have LS. Really? Should we do a biopsy? That's the patient asking. Clinician goes, no, we can't. It's so early. So what do we do in these like early stages? Can we make that call? Do we have to wait for things to kind of get bad enough so that we can biopsy? How do you what's your take on that?
So, I mean, I'm a big fan of kind of extended vigilance with it, if you will. So if you have a patient that comes in that says, hey, I have these symptoms, you do your exam, and, in terms of yeast stuff, as I've said before, I'm not a like, oh, you think you got yeast here? Let me call you in something. Like I'm going to culture it and stuff like that.
Thank you, as it should be.
Yeah, but I think it is completely appropriate if you talk to a patient about their quality of life with it. If you're like, hey, I'm really itching a ton. Let's say the itch is their main thing. It's waking me up at night, things like that. Okay, where do you itch? Where are you itching here? And they say, and you can see on their, let's say, labium majus, that like it's this thickened tissue and looks red. You say, okay, I can see where you're itching. I don't see anything white. I don't see any, fissures or cracks or things like that. There is something that is here. We know that this is, and it could be LS, but it could be, LSC, it could be a contact dermatitis, it could be whatever.
Yep.
And so for those patients, I have them kind of do a pretty thorough kind of like home investigative job, and then come back usually in about a month or so, and let's see how it's doing. So let's see if we can rule out any of the other stuff. Does it go away on its own? Because if it comes and it goes, and if it's not, a yeast or something infectious, okay, that's another diagnostic sign there, right?
Right.
So
it's like a slow process of elimination. Let's swab and see for all strains of yeast first.
Right.
Check for infection, these types of things. The home investigation, I'm guessing, is kind of in line with that contact dermatitis potential suspicion. So kind of, maybe stopping all the soaps and switching to a hypoallergenic detergent, see if that, if we can kind of pinpoint a product, or even something like a panty liner or a pad. Okay, I limit those because those can cause kind of contact dermatitis. So, okay, if they go home and they've kind of been like, oh, well, I stopped wearing pads, and then the irritation went away, then we can kind of be like, okay, then, very likely that was a contact dermatitis. Just don't wear pads and you should be okay, especially if, the yeast came back negative, no infection. But let's say there's like no infection, none of this, can't pinpoint anything specific that could be triggering a kind of contact dermatitis. They're still itching, they're still in pain, they're still burning, but you still don't see anything on the vulva. So is it vigilance, but maybe symptom management until there's something present that you see that could be biopsied? And by that, I mean, there's always something we can do. I really hate when patients are left with nothing, especially when they're like burning, I'm itching, because even if it's not a steroid, you can still, and like you said, to your point, like this is about quality of life. And so even if I can't make that diagnosis yet, because I can't biopsy what seems to be healthy tissue, and just, what are we going to do in the meantime? They're burning, they're itching. And so is that kind of the strategy, to mix vigilance with symptom management and like frequent follow-ups until there's something present that could be biopsied?
Yeah, that's what I like to do. And like you said, I mean, you can do trials of, you don't even have to do clobetasol or ultra potent, you could even do triamcinolone or, something like that, and be like, okay, does this respond to a steroid? I mean, that's another diagnostic tool too, and so I think that, and you could obviously offer biopsy to patients, say, hey, if this comes back, it's going to be early something. Now, if it says, if the pathologist says, hey, this is early LS, great, good, we caught it early, fantastic, but it may not say that. It may just say this specific findings, in which case we have to kind of treat symptoms as we're kind of watching the progression of this, so it is a quality of life thing, but it's also kind of making sure, if you are going to do a biopsy, I was taught in medical school, it's like you should only order lab tests that you know what the answer is going to be. And so it's kind of a similar idea with a biopsy. Like, I think this is confirming what I think.
Right.
Otherwise it's, let's order every lab test out there, and if you look hard enough, or with, check every lab box, you're going to find something abnormal. Does it mean that it's what the issue is? That's debatable.
Yeah, absolutely. And the thing is that, and we all have different pain thresholds, right? So some folks will, I know someone that told me they had 2 biopsies, then walked 15 minutes to their office, did a full day, walked home 30 minutes, walked the dogs, prepped the kids. And they're like, oh yeah, I was fine. And I'm like, oh, that would not be me, but that's okay. And then, there's other people that are like, need to take a week off and everything in between. So that's the thing with biopsies, is that if there's no signs, no obvious place to biopsy, then we're potentially putting someone through a painful experience and they're not even going to get anything back. And I've heard stories about that, where people get biopsies, it doesn't show anything other than inflammation. Monitor, 3 years later, confirmed LS, once there was like signs present. And so it's just, it's tricky. And I also know people whose clinicians will say, I can't biopsy because I'm not seeing anything. And they insist, the patient insists and says, I understand, I want it anyway. Sometimes it comes back as LS, and sometimes it comes back as those kind of non-specific findings. So it definitely is a challenge, and we'll talk in a little bit about, kind of mitigating pain and what we can do to make this procedure a little bit less traumatic, because unfortunately, I think there are still some barbaric ways that this is being performed, and I really don't understand why. There's literally no need for it. But let's talk about the biopsy procedure itself. Walk us through how you do it, which is like the non-barbaric way to do it. And then we'll kind of chat about, how other clinicians do it, and maybe how to advocate for yourself so that we can make this less traumatic than it has been for a lot of people.
Sure. So we do it kind of in a multi-step process. So the first thing we do is we do have nitrous oxide available in our office. Some patients want that. Some patients don't. We offer it, for a single biopsy. I think it honestly takes us longer to get the nitrous all set up and everything than it does to do the entire process. So that's something to kind of keep in mind too.
Yeah.
But so when it comes to pain control, obviously we do kind of a double layer anesthetic process. So we do a topical BLT cream, so it's benzocaine, lidocaine, tetracaine, on the tissue that we're going to biopsy. And the point of that is really to numb the tissue for the actual numbing injection.
Yeah.
Because then the second thing we do, we use bupivacaine in the office. It lasts a little bit longer than like straight lidocaine.
Mm-hmm.
And we use a 30 gauge insulin needle with it. So it's a tiny little needle to inject it. And that is the worst part of the whole thing.
Yes, exactly.
Because, but really, I mean, for most biopsies, at least the ones that we're doing, I can get away with injecting like 1 cc, maybe 2 of local anesthetic. You don't need like this giant thing because the actual biopsy part is we use what are called punch biopsies, which are circular biopsies. They look like a little pencil. They have a circular blade on the end of it. And we use either 2 or 3 millimeter biopsies, depending on where we're biopsying. And basically you just push it into the skin, twist it, a few times, and it creates kind of an incision in a circular fashion. And then that is, held up by a little stalk on the bottom, and you kind of, cut that and put it in your formalin container. And that is literally the biopsy,
Yeah.
I've had patients laugh through biopsies before. We've had, people just carry on conversations. We use, for most patients, silver nitrate if we need to stop the bleeding. So it's a topical, what's called styptic, and it kind of cauterizes it. But you can put a stitch in. You can suture it shut.
Right.
They usually have to go and have that cut out later on, which is another thing.
Mm-hmm.
But then we will often have them put either Vaseline or A&D ointment or some other barrier on the biopsy site for the next 48 to 72 hours, basically to allow it to scab over so it's not getting caught on the patient's underwear or clothing or whatever like that. I mean, and my experience, at least with my patients, is similar to what you're talking about, the, patients that come in that then go back to work or they do whatever, like, they don't need, or I haven't had any of them take time off for it. If they did, they didn't tell me. But, it seems to be, at least with the exception of the numbing shot, which I really wish there was something I could do, but it lasts for 2 seconds. And I've, in the spirit of exploration, have said, okay, well, I'm going to inject myself with numbing things and, the kind of respective area. And as that did not feel good, obviously.
Right.
But it, was gone in a couple seconds and then you're numb. So, that's kind of the thought.
Yeah. And I think, there's so many layers to this, but one is that, for people, especially for folks who've been suffering for a long time with pain, who have, experienced medical gaslighting, medical trauma, they're sitting on the table, incredibly scared, in a really vulnerable position. You're potentially biopsying a place that, because not everybody itches. For some people, it's pain. They're already so scared. And then what a lot of clinicians do is, one, they don't explain the process. So the person who's getting the biopsy has no idea what to expect and what's coming next. And they don't numb the skin first. So to your point, it's the numbing injection that hurts the most. But most doctors will just put you down and go right in with the needle. So no numbing cream. They don't even tell them, hey, this is going to hurt, but just for a couple seconds, breathe in with the nurse while we do it. They don't say anything. They just go in and inject. And, I don't really understand why, because numbing cream seems like such a simple thing to do. It's not it's not surgery. It's, you're really just applying cream to the area that you're going to inject. I don't know why this step is skipped in so many places, but unfortunately it is. And so I end up having to tell people to ask first, is the doctor going to numb the area with cream? If not, request that they do. And some people have to bring in their own numbing cream in Canada. So, Here, we can get things like EMLA over the counter. And so what some people will do if offices do not do it, they'll purchase EMLA over the counter and then apply it the day they're getting their biopsy, about a little bit before. They'll chat with the pharmacist and say, approximately what time, how long should I put this on before I get it? And so some folks have to do that. But yeah, it's really strange to me that step is just kind of glossed over, especially if you don't inform the patient about what's about to happen.
Yeah, I don't understand that either with things. And I mean, even so, in places I've been in the past where we didn't have numbing cream, the other thing you can do, and this is for any type of injection, you have the patient cough at the same time they're doing the injection. It does a little short circuit thing in their brain, and you don't notice the stick as much. Now, obviously, once again, lidocaine or its derivatives, they burn. So that's the other thing. You say even if you can avoid the stick, that burn may still, you can still may feel that. There we go. But it was really interesting. I've talked to some patients, and they've had these type of almost like what are called crush biopsies done in the past, which is with a device similar to what you'd use if you had an abnormal Pap smear, and to get a biopsy of the cervix. They're called Tischlers, and they look like they have like a little kind of cup on the bottom, if you will, and it's got a big tooth here. And the cup has a little bit of an edge to it. And so you put the tissue in there and you squeeze it, and it basically, chomps into it, and you get this section of tissue in the little cup. I mean, that's going to be horrible on the vulva. It's a big, long instrument. So you're like a conch.
Right. Yeah.
But secondly, the other thing too is if you crush the tissue, it can make it much harder for the pathologist to read it.
Yeah.
And so that kind of gets into other types of biopsies. You can do like a shave biopsy where literally you just kind of shave off the top layer of the skin there. You have to just be careful how you're picking it up. Are you going to crush it or not, especially if it's really thin? So there is a little bit of technical know-how with these, but at the same time, this is a very simple procedure that just needs simple numbing, kind of. You think about it, you get a numbing, like a procedure anyplace else, you're going to need multiple types of numbing medication. The EMLA cream is a great idea, too, for patients who, if they're, the provider they see, their office doesn't offer it. So,
well, and I always think, when I've had a cavity done in my mouth, they never inject first, right? It's a two-step process. What they do, they apply a gel to the gum that they're going to inject. And then they say, all right, we're going to let that gel sit for 10 to 15 minutes, numb it up a little bit. We'll be back, go in with the injection. Now, when they go in with the injection, I feel it a bit, but not as much as if they skipped the numbing step. So it's so interesting. And I had to get a biopsy once on my nose. I had like a teeny tiny growth, right? And that was like the best experience of my life. The doctor was so kind. He walked me through everything. He really numbed my nose first. And I was like, man, all this for this teeny tiny little thing, and people can't numb a vulva going in for a punch biopsy? Like, that was a shave biopsy that he did basically on the nose. And so it's interesting that in so many other areas, there's such care taken with respect to pain management. And then like when you're doing it on the vulva, on such a sensitive area of the body, it's like that goes out the window, which is why I say it's kind of barbaric when you think about it. Again, like I was so astounded. I was like, oh, I wish all vulva biopsies would be like the nose biopsy, because that was like, it wasn't the most comfortable thing, but it was overall, I was very happy with with how it went. And I think, correct me if I'm wrong, the reason punch biopsies are kind of the gold standard for diagnosing LS is that the shave is only getting that top layer. And because LS is a kind of skin deep condition. And so you really need to get all the layers, multiple layers of the skin, to see all of those markers to make that call. Whereas if we just get that top layer, that may be insufficient. And so that could also be a reason for potentially getting a false negative, is that the right type of biopsy wasn't performed, or the biopsy wasn't performed maybe in the right place.
Right.
So there was LS in one place, but the clinician wasn't trained enough to know where they should be biopsying. And on that, as we're talking about the procedure itself, are there any areas that you avoid? For instance, the clitoris, would you like say the only sign that you could see was on the clitoris? How would you approach that? Would you do a punch on there? Would you take it from an area as close to it as possible, but that's not the clitoris proper?
So I don't biopsy the clitoris in the office. So
Okay.
first of all, we can do dorsal-clitoral nerve blocks, and we can make, pain control can be done, but it
Right.
is so vascular,
Yeah.
and that I don't do it. And so for me, if I do a clitoral biopsy, I actually have operating loops, like those like surgical glasses that
Mm-hmm.
magnify things, so I can
Right.
really kind of see exactly what I'm doing. And I do we will put a little suture right through the middle of the area that we're going to biopsy, and I kind of make a little circular incision around it, so I kind of tint up the tissue and kind of go
Okay.
around it like that. So I'm, with a punch, as you're barrowing it, or well, I can't even talk today, burying it into the tissue to try and get all
Mm-hmm.
those layers. That, well, okay, if you're on the vulva, for instance, I'm going to get to subcutaneous fat, we're going to be okay. Well, the clitoris, you don't really have that, so you don't
Right.
just want to be like, digging through it,
Exactly.
and so that's my kind of technique for the clitoris. Now, if it's on the, let's say, the hood, and it's right by it, I mean, still, I'm going to do a modified version of that technique
Mm-hmm.
too. So I personally am only going to do punches on, I'll do punches on the vestibule,
Mm-hmm.
definitely the perineum, perianal, but
Right.
areas where I know kind of what's back behind the structure, if you will, that there's
Mm-hmm.
a stop zone
Yep.
that I'm not going to damage if I, go deep with it. So.
Mm-hmm. Yeah, that makes a lot of sense. I'm just going to go back to a conversation we were having earlier before I kind of wrap things up. And that was, we were talking about, it could be early LS. We're not sure. We're talking about managing quality of life and, managing symptoms, and saying that, potentially a weaker steroid, something like triamcinolone or even lower, could be given
Sure.
in the interim. And if the patient responds, that is still a kind of clue that can help with that diagnostic picture. And it kind of made me think that some places in Canada and Europe tend to prioritize clinical diagnosis over biopsy. So how they do it is, okay, what are the clinical signs? What are the symptoms? Let's give a steroid and see how they respond. And if the symptoms
Sure.
are present, there are signs present, and the patient responds to the steroid, they kind of take that as like their confirmation. And it's only if the patient doesn't respond to the steroids within a 3-month period or so, if they're not responding at all, that's when they start to say, maybe something else is up. Let's take them off for a few weeks, flush it out, and then do a
And do the bio.
biopsy.
Sure.
Yeah. So I think it's also interesting to note that different countries do have different ways of approaching this, and sometimes that's a challenge for patients, right? In Canada and some European countries, we have to really, really, really fight for biopsies, whereas I find that American patients have a little bit of an easier time advocating for that. So um, I just thought that was kind of an interesting point. And then moving forward, do you have any advice for patients to advocate for a biopsy? So I'm having itch, or I have pain, I want my doctor to biopsy, but I don't know, or they tell me I have LS, but I want a biopsy to confirm it.
Sure.
How might I ask for that in a way that, a clinician would respond to potentially?
Well, and it's something, and I would go on the side that is, hey, there are other things here that look like this,
Mm-hmm.
and I understand that you can say, well, okay, you respond well, and I think this is, but I'm nervous. Like, what if this actually is, VIN, like
Mm-hmm.
vulvar, precancerous cells?
Yeah.
Yeah, I may have LS, but what if I've got VIN 2? What if I have
Mm-hmm.
VIN 3? What if I have, you know, whatever it may be, carcinoma in situ, you're not going to really be able to see that, with just the naked eye. And yeah, you'll have some response, their symptoms may improve.
Of course.
But, if there's a lesion there, for instance, and you're like, okay, well, it doesn't really itch as much anymore, but yeah, there's still something funky. I think definitely that's hey, this needs to be biopsied. But my kind of thought as far as advocating is really kind of, saying, hey, come for confirmation and to make sure, because we know that LS specifically has that cancerous potential.
Yeah.
I want to make sure that I'm not dealing with even anything precancerous with this. And that is what the biopsy would show you.
Yeah. And I think that's great advice. And it's really just, sometimes we have to speak the language of the person that we're talking to. And I think really approaching it from that kind of scientific, rational perspective would, hopefully get a good response, and really just saying, I understand that it's not going to be a comfortable procedure. I know what it entails. And nonetheless, this is something that I want for X, Y, and Z reasons. So, and then if they don't do it, because I understand that some offices don't, especially if the person diagnosing you is a GP, PCP kind of practitioner, to be fair, they may not do biopsies. They may not have the tools nor the experience or training to do it. So then saying, if you can't, could you please refer me to a clinic that will or that can do these types of biopsies? Because it's true, especially, with the NHS, a lot of people's first point of contact is going to be a PCP. So they're a GP, so they may not be able to do a biopsy anyways. And so that's okay. But then saying, please refer me out. And the other thing I do say sometimes is that if anyone denies you, ask them to document that on your file. Say, okay, I want it documented that I requested a biopsy and you declined it.
Sure.
Because you never know. I've had not so many, but enough cases where doctors say, no, I'm not going to biopsy. And then it turns out that there was cancer present. And they just kept getting refused biopsies, even though there was no grounds for the refusal whatsoever. So that definitely is something that is very frustrating.
Yeah, I had one of those recently where it was a patient that came to us as like a second opinion. And, she had this, she knew she had LS, but she's like, this one spot had just been getting worse and worse. And they had, no one had, said, hey, let's biopsy it, nothing. And so we were like, oh my gosh, and took one look in the office and said, and it was on her clitoris, so we go to the OR, we biopsied it, and it was squamous cell. So
yeah, it's just, it is those types of things that's so frustrating, because I don't understand why you would deny a biopsy in that kind of circumstance. Like, we interviewed Johanna, who's Vulvar Cancer Awareness Forum in the United States. We interviewed her and she requested a biopsy, I think over 20 times. Lesions that would not heal for years, decades, and she just kept getting denied, doctor after doctor in these big hospitals, and it just made no sense. And it was so frustrating because she didn't have to end up like the way, as sick and as in pain as she did. And she documented every refusal, because she was like, this is ridiculous. So yeah.
Well, I think with this lady that, that came in the second opinion, she came from out of state, so she, and it's ludicrous to me. Obviously I'm happy to see her, but it's like, there should be, even if not your regular, in this case, gynecologist, somebody locally that would do this. Like, you don't need to go to, for just a straight biopsy for, one of the vulvar centers, hopefully, so it's crazy. And I don't know how to change that, other than just like you kind of alluded to in the beginning, people are learning more about it. Maybe we'll see it get into medical education more, and especially, GYN, derm, kind of GP, PCP type, training to where they're more comfortable with it. But we'll see.
Yeah, 100%. Yep. Here's to hoping for sure that, next 5 years will be a lot different, and maybe even, down the line, we'll have some easier diagnostic tools to make this even less invasive, right? Of course, that would be wonderful if we could I mean, I think I would opt for a blood test or an ultrasound over a biopsy if it was available and it was a solid, way to confirm diagnosis. Although right now, those are the two ways that we got diagnosed. Is there anything on the topic of biopsies that you wanted to mention, but we didn't get to today before we kind of close out?
I don't think so. I mean, we talked about the main things that, I wanted to kind of like at the pain control thing is I think the big thing. And,
Yeah, I agree.
the patients need to be given appropriate pain control. And that can jump onto the soapbox of misogyny and, pain control for just, women's health in general. But I think it is one thing, talking to your provider and saying, if they say, hey, we're going to do a biopsy, okay, well, how do you do things? How do you numb stuff? And then, Imla cream, or even like you could even get, I mean, there's a stuff over the counter here called solar cane, which is for sunburns.
Okay. Right.
I mean, it's not super duper, high potency. But the other thing you have to remember too is that squamous tissue, so like what's on the labia and the majority of the vulva, it takes a lot longer for stuff to get through than it does like in the vestibule or especially the vagina. Right. Like we can put that BLT cream in the vagina and like a couple minutes later it's totally numb.
Oh wow.
It absorbs through those mucous membranes super well. You gotta let it soak into the squamous epithelium.
Yeah.
So that's the other thing too, is like you kind of talked about putting it on before you go into your visit, and hopefully that will allow you at least get some of the pain relief from the needle stick.
Yeah, and a pharmacist should be able to give you a recommendation for like approximately when you might want to apply it. Just say I'm going in for a vulvar biopsy. I want to be pretty numb by the time they put the needle in. How long would you recommend putting this on prior to, that procedure? Pharmacists are really great with that. So I think we sometimes underestimate them in our VLS team, but, they have a lot of knowledge too that we can tap into. So yeah, and we at LSSN do have a post on, caring for yourself for a biopsy procedure, things that you can do before, during, and after the procedure to make it as comfortable and as safe as possible. So you'll definitely want to check that out. Corey, for anyone that wants to see you in your office, Haven Center, how can folks get in touch and book with you?
Yeah, easiest thing probably is to go to our website. That's www.havencenter.com. It has all the information about what we do, how we do things, and then there actually is a place on there you can schedule, online for either an in-person visit or obviously if you're we're in Oklahoma, if you're outside of Oklahoma or even in Oklahoma, you want to do a virtual kind of education visit to talk about things before making your decision whether you want to, make the trip to see us, and that's another thing on there as well. So,
yeah. And I tell people that a lot too, because I think that's the thing is a lot of people are nervous to just book plane tickets and see a provider they've never interacted with. They don't know what to expect. They have all these questions. And so I think it's nice to have that virtual consult option so that you can chat, get to know each other first, and then be like, yeah, okay, to Oklahoma I go.
Sure.
that can be nice because for some folks are flying, from Europe, right? So it's a big deal for them. That's quite a plane ride, quite a journey. I'm also just gonna shout out your Instagram and TikTok because you're an awesome content creator. So folks should definitely go over there and follow Dr. Babb as well because you have tons of great informational bits of content. So yeah, with that, thank you so much, Dr. Babb. Thank you for everyone as always, and we'll catch you in the next one.
See you later.
Bye.